Thank you for joining us for this recorded web presentation, Sexual Violence in Later Life, Strategies for Healthcare Providers. Please take care of yourself during this time. All of the information in this presentation is based on the Technical Assistance Guide for Healthcare Providers, Sexual Violence in Later Life, created by the NSVRC. Presenting for us today is Jennifer Pierce-Weeks, and I'm going to pass the floor over to you, Jennifer.
Thanks so much. As she said, my name is Jen Pierce-Weeks. I'm a registered nurse and board-certified sexual assault nurse examiner for the adult and pediatric populations. I've been a nurse since 1986. If there's something in this training that you take away that goes a little beyond what you get in the guide itself, hopefully that will be an improved knowledge of how to respond to possible sexual abuse in the clinical setting when you see it. In addition, all of the literature referenced will be listed at the end of the presentation. So the U.S. Census Bureau estimates that by the year 2050, adults aged 65 or older will account for 25% of the population. National data suggests that 3 to 5 million older adults experience some form of abuse annually. And the National Center on Elder Abuse found that between 1 and 2 million Americans aged 65 and older have been injured, exploited, or otherwise mistreated by someone who they depend on. The CDC classifies sexual violence as any sexual act that's perpetrated against someone's will. The definition encompasses a range of offenses perpetrated against both women and men, and you see those here. Sexual violence against older adults occurs in both home and institutional settings, and it involves older adults who do not or cannot consent. Often the sexual violence is committed without the consent of the person harmed because of cognitive or other types of impairments. And because sexual violence involves both medical and legal arenas, it's important for healthcare professionals to understand that not all sexually violent acts are considered illegal. It's never the healthcare professional's job to determine if a crime has been committed. That's law enforcement's job. It is important for providers to understand that jurisdictions and agencies have different definitions of elder. The National Clearinghouse on Abuse in Later Life considers older victims to be age 50 years and above, while most state laws identify people as elderly beginning at either age 60 or 65. There's wide agreement among researchers that abuse of older adults is a large-scale problem that has been inadequately addressed in healthcare settings. You can see the SANE-A study here. Healthcare professionals need an understanding of all forms of older adult abuse because sexual abuse is often found when a variety of abuses may already be occurring. This is true when the abuse occurs at home or in an institutional setting. So the bottom line is, if other forms of abuse are present, sexual violence should be explored as well. You can see the results of the New York State Elder Abuse Prevalence Study here, which looked at all forms of abuse, not just sexual abuse. Within the larger context of elder mistreatment, sexual violence rates specifically are low. It is important to note that of those that were sexually violated, though, only 15.5% reported to police, and this is really significant. We already have difficulty in regards to the rates of reporting in the adolescent adult population, not even looking specifically at elders. But instead of looking at that 0.6% sexual violence victimization, because it is difficult to tease sexual violence out of the other forms of abuse, which we're going to talk about, it's really important to recognize how difficult it is for these patients to report. As with sexual violence against younger people, lots of factors influence disclosure or reporting rates. For example, it's common for intimate partners and family members to be identified as offenders. and this creates problems in its own right in regards to reporting, and lots of people may be being cared for by those family members, and it may make it very difficult for them to come forward and speak about it. You can see here in Ramsey-Klosnick's study, 81% of the offenders were care providers. 78% of those identified as family members, primarily sons and husbands. So when you consider that intimate partner violence is an overlapping factor in the sexual violence that may be going on for some of these elders, and they're in a home situation, you can imagine how difficult it may be to come forward and report that. There are lots of barriers to reporting, just like any other sexual violence victim, and each patient is very individualized in regards to their reasons for maybe not coming forward or choosing to come forward and report. Lots of times we hear things like, this is the person who's caring for them, and so they're afraid. They're afraid of losing their family members if they tell. They're concerned over their own personal safety because, again, it's not uncommon to have physical abuse going on at the same time that the sexual abuse is going on. The elder may also have physical or cognitive impairments that make it very difficult for them to report. And in fact, it's not uncommon for healthcare professionals to assume that a cognitive impairment is causing the person to say something that they might not otherwise say and just simply not believe them, not think that they are clear about the sexual abuse that's going on. And then there are offenders who make threats against elders, and that causes them to choose not to report. So there are lots of reasons. The key really is when you're talking to your patients to talk to them as the individuals they are, because if you ask direct questions, we find that patients will often tell us exactly what the issues are in regards to reporting or in regards to sexual violence, which we're going to talk about. So take a look at the National Elder Mistreatment Study data here on the screen. And does the reporting rate surprise you at all? In truth, it's not really possible to look at someone and know whether or not they're capable of being abusive toward an elder, toward a parent, toward a family member. But there is research that allows healthcare professionals to raise some red flags of concern that abuse may be a factor or abuse may be going on. And you can see some of those characteristics here. What we do when we teach healthcare professionals is we really talk to them about the red flags. In the presence of a red flag, it doesn't necessarily mean that that patient is being sexually abused. It means that you, the healthcare provider, should explore further the possibility of abuse, because one of the things we'll talk about is that safety for that patient is part of the healthcare professional's responsibility. Earlier research on elder abuse generally has shown also that unemployment by the care provider, or stress, fatigue, dissatisfaction, a history of violence, psychological or physical impairments, and poor impulse control, as well as a lack of knowledge of the duties, resources, or services that are available might also be factors in the abuse. So it's really important when you're talking to your patient to gather information, which we're going to talk about, but also when you're speaking with care providers or family members, it's important to get information from them as well. Often they can lend important information as you try to determine how at risk your patient might be for being sexually victimized. You can see here the offenders that are also identified in care facilities, and you know, it's almost evenly split between the employees who are responsible for that older adult's care and the residents themselves. There is not a lot of conversation about, honestly, the sexual violence by residents. In the first national study of sexual violence against older adults, one of the most striking things to me, professionally speaking, was the significant delay between the report by the elder and actual action taking place with regard to things that we really know to be standard approaches when we believe someone has been sexually violated. The delay in reporting of both abusive staff as well as the reporting of sexual violence in general, when an elder mentions that, is very outside what we consider the standard of care to be for sexual assault victims. And this is one of the things that I really want to get to as we discuss the appropriate approach for sexual violence in the elder population. One of the things seen here is not just the delay in reporting of abusive staff, but low prosecution rates, which are across the board with sort of all sexual violence populations. But also 11% of older adults that did report sexual assault received a medical evaluation, 11%. So 100% of sexual violence victims have health care implications, which really means that 100% of sexual violence victims should receive medical forensic exam. Whether or not it includes evidence collection is a different discussion, and we'll talk about that. But there are health implications for all patients who have been sexually victimized. So really all patients need a medical exam, and we're looking at, roughly 90% not actually getting that. So the health consequences of sexual violence for older adults are not often teased out in the literature. You can drown in the literature on health consequences for other patient populations, but because the data is so small and limited with regards to elders and sexual violence, it's hard to tease out specific health consequences for them. What you can see here, though, just looking generally at populations, is that the health consequences that do exist when you look at the data on adult women span all of the body systems, really, and they impact both physical as well as the mental health of the patient. And they're not just acute consequences, they're long-term, significant health consequences over time and over a lifetime. So it's really important that healthcare professionals deal with sexual violence at all levels of patient care, and it's incredibly important that we begin looking at the health consequences for the elder patient population who may have experienced sexual violence. So you can see here that intimate partner violence plays kind of a key role and specifically contributes to a lot of the health issues that you see here. One of the things I want to point out on this slide, though, is that in one of these particular studies, those who reported abuse had a mortality rate 2.3 times higher than patients who did not, whether or not the abuse was substantiated. And the one thing that they were clear about in the research is the precise mechanism of the association between the abuse and mortality are not clear. So we don't know necessarily why that is, but we know that it is. And it's really important to look at that when you consider the elder population who start out oftentimes with health-related issues, some physical, some cognitive, some mental health issues, and the generalized medical issues they bring to the table before you even consider that mortality rate. So intimate partner violence is a huge issue, and there is enormous overlap with sexual violence and intimate partner violence. So what are the indicators that you will see as a healthcare professional if your patient isn't walking through the door saying they were sexually assaulted? You can see some of them here. So certainly one that cannot be ignored is the disclosure of a patient saying someone is doing something sexually inappropriate to them. The presence of intimate partner violence makes sexual violence something that needs to be explored. So when you as a healthcare professional know that the patient has already disclosed abuse by their partner, it's important to ask the right questions about whether or not sexual abuse is part of that equation, and we'll talk about how to do that. And you can, of course, see some of these other indicators. Here are a few more that we look at: the unexplained bleeding or injury in the genital area, sudden changes in behavior, a new HIV diagnosis, mouth sores or any kind of oral infection, or unexplained injury in the mouth, and strangulation. And one of the things I will point out is that strangulation in a living patient with or without symptoms warrants a really thorough medical evaluation. This is something that often does not happen. The reason that it requires that is because there is a risk of delayed lethality. We hear about strangulation cases certainly where the person actually dies at the time of strangulation. For folks who don't work in death investigation, like myself, who work with living patients, what we see are complications that happen from the strangulation event hours to days down the road that cause issues that are lethal, that cause the patient perhaps to die 3 days from the strangulation event. So it's really important that healthcare providers educate themselves on strangulation and what the medical needs of that patient are, and how to do a proper assessment and make sure that correct testing and assessment goes on for the patient population, especially when the patient is an elder. Also, just ensuring appropriate care. So offering a medical forensic exam, again, with evidence collection or without, is the standard of care. When you know someone has experienced sexual violence, they need a medical exam because of the health consequences. Oftentimes people think that, well, a medical forensic exam involves the kit. We don't know anything about the kit. We don't know how to do evidence collection. It actually doesn't necessarily always involve the evidence collection kit, although we're going to talk about that. Providers, they need to understand that because the health consequences are present, the medical forensic exam should be present. The forensic part of the exam, or the legal part of the exam, doesn't necessarily have to be an evidence kit. Every part of any care that you give to a patient can become legal at any time. All that requires is a subpoena, and the chart is forensic. The chart is going to come in as evidence. We associate forensic with the sexual assault kit. Sometimes patients are outside that window of evidence collection, which we'll talk about as well. So offering a medical forensic exam when you believe someone has been sexually assaulted is part of the standard of care, and the provider may need to make a report. They may be a mandatory reporter. It depends on your location, of course. And the report may be to Adult Protective Services, law enforcement. It may be to both. It may be to the health department, depending on whether or not the sexual assault is a licensed care facility. It just depends on the circumstances. So you need to know as the provider what agency to call and under what circumstances you're a mandated reporter. And you can find those resources, too, in the guide. So one of the terms that we hear a lot lately, I think, in healthcare is something called trauma-informed care. Trauma-informed care is really the newest and most appropriate approach for patients who've experienced trauma. Trauma-informed care recognizes the impact that trauma has on health because, again, we now have so much data to suggest what trauma does to health consequences over time. And trauma-informed care promotes healing, and it promotes an approach that avoids further traumatizing of the patient, and that's what we want to do here. Often healthcare providers are in such a rush that the perception of the patient is that the provider doesn't care about what happened to them. And for sure I can say this is true in the emergency department. The patient might also feel like they're burdening you by telling their story, like they're taking too much of your time, when in fact if you just take a few minutes to sit face-to-face with that patient and let them know that at that moment in time they're the priority, oftentimes they will tell you things because they believe that you're sitting there and you really want to know what the answer to the question is. I have seen so many providers, both in giving care with them and in receiving care myself as a patient, who ask questions without even looking at the patient, without even making eye contact with the patient or having their back turned to the patient. It's a really clear message. If you can't even look up when you're asking questions about violence, that they're pretty clear you don't necessarily want to know exactly the truth about the violence going on in their lives. So your approach is really important. Simple statements by you that hold the offender accountable can go a long way toward decreasing the traumatic effect of sexual violence. So simple things like saying to the patient, this is not your fault, or I'm sorry this happened to you, when they are talking about the sexual violence, is a huge deal to that patient's recovery, and to letting them know it's really okay to talk about, and you're not going to ignore what they're saying. The other thing is, a lot of choices have been taken away from this patient population, particularly when they're being violated against sexually. And oftentimes it may not be a one-time thing, it may be an ongoing thing. So taking that into consideration, the patient's autonomy and self-determination become really important. And honestly, in healthcare, this is really part of what we call evidence-based practice. And we often talk about evidence-based practice like it is just the research, applying the research to our care, but it goes beyond that. Evidence-based practice has everything to do with what we know the best research shows, combined with what we know clinically actually works for patients, and then what the patient wants. Because we can talk about the research all day long, but if that is not the approach the patient can take at that time, if they don't agree with that, if they don't feel like they can come on board with a plan of care, then it's not going to work. So evidence-based practice says that we always take into consideration what the patient wants and their own autonomy, their own self-determination. Here you can see the trauma-informed care principles, really. One of the most important, from my perspective as somebody who works with sexual violence victims, is giving that patient access to longer-term services beyond your care, to the sexual assault advocacy services specifically. On this list, that's the last thing listed. But in my mind, it's the most important thing that we offer. Depending on your setting, you may only be seeing that patient once, or you may see that patient every day. Whether you're seeing that person once or you see that person every day, the people that provide the ongoing services specific to sexual assault are the community-based advocacy services folks. So that is one thing that we can do as healthcare providers, is engage that service so that patient has ongoing support that actually that specifically deals with sexual violence. All of these other things are equally important, but I just want to highlight that one because I think it is fundamental to the work that we do and the services we provide patients. And we make referrals all the time. We bring people in all the time to help with patients if the cases are complicated. So this is not outside our realm of service provision, and it's also not a violation of the patient's privacy. And, that may be something that we can talk about as we get a little further into the training. The other thing to be aware of is the Joint Commission on Accreditation of Healthcare Organizations recognizes that care should be delivered according to the patient's needs and with the highest possible quality. That said, the Joint Commission addresses both the individual healthcare provider and the facility's responsibility in regard to all forms of maltreatment. They have very specific standards outlined in the Joint Commission, and providers should be aware of that and aware of what their responsibilities are in regard to that, because the Joint Commission is not silent on whether or not abuse should be recognized by healthcare providers across all licensing and addressed through policy, through procedure, and approaches in treatment. There are also facility expectations. You should expect your facility has a plan for protecting patients for abuse, because again, this is one of the things the Joint Commission requires, whether you're a hospital or whether you're a long-term care facility, that evaluates every suspected case that occurs and that reports all cases to the appropriate authorities when reports are supposed to happen. It also should secure a medical forensic exam, because again, that's part of the Joint Commission standard. So that does not really sit well when you consider that only 11% of elders actually receive a medical forensic exam. In many hospitals, a sexual assault nurse examiner has taken on the role of meeting the forensic needs of the patient who may have been victimized. A SANE is a registered nurse, minimally a registered nurse. There are advanced practice nurses and physicians and physician assistants who also work within that role, who has been trained in the comprehensive care of sexually assaulted patients of varying ages, and it includes appropriate evidence collection. If your facility employs a sexual assault nurse examiner, it's appropriate to utilize them for older patients who might have experienced sexual assault. However, most health systems don't have 24-hour available SANE-trained personnel. One of the things we see happening across the country is, well, we don't have a SANE program, we don't have SANE nurses, so we can't help this patient, so nothing gets done. The fact is, in the absence of a SANE program, the provider still has an obligation to provide the standard of care when sexual violence is suspected. For that standard of care to be met, all staff must be educated in how to identify possible older adult sexual violence and the response required for an effective intervention. So it's not really enough to say, well, we don't have a SANE program. It's not even enough to say these are some of the other things that we've heard. You're outside the evidence collection window. In adult patients, the evidence collection window is up to 5 days following the sexual assault. And we hear of facilities all the time who say, well, there's nothing we can do because it's 7 days since you were sexually assaulted. The standard of care has not a lot to do with the evidence collection specifically. It has to do with the health care needs that that sexual violence victim faces, and they need to be seen. The other thing to remember is that the patient is always the best historian, and that privacy is critical. Every health assessment that we do, whether we're a registered nurse or a physician, involves gathering a history. Typically, the most accurate history is from the patient. Now, of course, there are some older adults who have some cognitive issues, and you may have to get history from other parties, and that's perfectly okay. But no assumption should be made that the patient is not aware enough to give you an accurate history. No assumption like that should be made. The other thing is, just to touch on what is up on this slide here, is sometimes we're, as providers, influenced by what other people are telling us instead of just taking an unbiased approach and talking directly with the patient. I think this happens more with the elder population than with other patient populations. We see it happen with children too. We're so used to talking to other people to get the history that whatever is told to us is automatically believed, and it creates a bias. So we already have a belief going on before we get to the patient, before we talk to that patient and hear what that patient has to say. And that can skew what your response for that patient is going to be. So you really want to try to avoid the bias that other people can bring to the table. Sometimes we see that come in through law enforcement. Sometimes law enforcement will bombard us and try to give us a history of the sexual assault before we have a chance to talk to the patient. That can create a bias as well. The patient is the primary source of information. The other thing is really taking a look back through that patient's medical record history can be particularly helpful. And it's something that providers should do when they're seeing an elder who has has sexual violence on the list of differential diagnosis, because they may have been seen for a variety of different chief complaints that are all red flags towards sexual violence having occurred, and that is helpful information for healthcare providers to know. The other thing is, of course, getting the history privately and away from other people. One of the things that we teach providers is, sort of jokingly, sort of not, if you are talking to a 14-year-old girl and you want to know her sexual history, if you ask in front of her parents, you're not likely necessarily to get the actual sexual history. The same applies to elder patient populations if you're asking about sexual violence specifically and there are any caregivers or family members in the room. Particularly if you consider that the perpetrators are often caregivers or family members, the privacy piece is critical. When we teach people about this in the domestic violence world, we say, do not ask the question if you cannot achieve that privacy with the patient, because you don't want to put that patient at risk of, greater safety issues because you're asking questions in front of a potential perpetrator. So the other thing is, because I always get asked these questions in teaching in live settings, is depending on the patient and the family, privacy can be really challenging depending on your healthcare setting. It may be that you cannot get a family member to leave the room of that patient, and it makes it very difficult to ask directed questions about sexual violence. What I will say about that is to be strategic about finding ways to see and speak with that patient alone. Depending on your healthcare setting, there's almost always a circumstance that you can come up with where it can just be you and the patient. In the emergency department, we often use radiology or X-ray departments as our go-to place for this kind of approach, because no one but the patient is allowed in the X-ray room. They simply don't allow it. And they have the radiation banner to keep people out. So that happens to be the place where we do a whole lot of private conversations when we're worried about sexual violence, because we don't know anything about that. The other place we do a lot of conversation about this type of thing that we know we can be alone with the patient is in the bathroom. It doesn't sound very attractive, but if it's the only way that you can get that patient alone to have that brief conversation where you're asking specific questions about sexual violence, then be strategic and find that place. Healthcare providers are very effective at finding strategies to get patients alone. If the older adult is experiencing cognitive difficulties, getting a history from the family or the caregivers is really valuable. If the older adult lives at home and relies on a caregiver, the caregiver might be able to inform providers of recent issues with the patient, as well as challenges that they are facing, which can sort of help you red flag a family if you need to. The key is to really let that person talk about what they see. And that way you're still maintaining that patient's privacy. You're letting the caregiver talk, you're letting the family member talk, versus you talking to them. Maintain that patient's privacy while you gather information. The other thing to consider is really having some questions in mind ahead of time that can be helpful in in figuring out whether or not you should have concern about this patient. So think back on the conversation that we had about the red flags. What questions might you ask family members or caregivers that would give you an indication of just how stressful the environment is? Regardless of the circumstances where you're seeing this patient, you always want use good communication techniques. So address the patient directly and, again, privately. Stay or try to stay in that patient's line of sight. Consider, too, what medication regimen the patient is on and what is going to be the best time to talk to them when they're going to be the most alert. And so if you are in a longer-term care facility, there may be very specific times of day where the patient is alert and easier to talk to than other times of day. Planning your conversation around that can be really important. Speaking clearly, not loudly, is also very important. And asking one question at a time. Because if you ask multiple questions in one sentence, it can be very confusing to the patient, even if they don't have cognitive difficulty, and you may interpret their answer as an answer to one of the three questions you just asked when in fact it was the answer to number 3. So it can confuse you, it can confuse the patient. So one question at a time. And then reassure the patient that it's okay to be talking to you, that this is a safe place to have a conversation about, and you're concerned about their well-being. We also know from experience that avoiding direct questions about sexual violence results in patients not sharing their sexual violence histories. We know this across all age groups. So this is one of the reasons that we make the recommendation that you ask direct questions. And you have to, because some providers are comfortable talking about this and others are not comfortable. I would say that lots of times providers across the board are uncomfortable talking about sexual violence. But when you think about all the other questions you ask a patient in a day, you ask sexual-related questions all the time in a whole variety of different practices. And you don't think anything about it until you're talking about the issue of sex and consent. And then it becomes uncomfortable. And you feel like you're wandering into an area that is private and maybe you shouldn't go there. It is our job to ask patients questions that go to their health and their safety. And finding the series of questions or the one question that works for you and practicing that can be really helpful. And understanding that one question, depending on that patient's answer, can kind of lead you down the road to the next series of questions. So it's a matter of getting alone with that patient and then asking direct questions. Are you going to start with the sexual violence questions? Probably not. You can start with a whole host of other more general questions and work your way to that specific thing. The other thing is let them know ahead of time why you're asking. Let them know that this is a common problem, and so you like to ask your patients about it directly. Totally appropriate to set the stage for why you're asking those questions. And a full physical assessment should always take place. It's not a targeted assessment, which is what we see going on these days in the emergency department. You came in with ear pain, I'm only going to look at your ear, I'm not going to look at the rest of you. That's a targeted assessment. Look at the entire patient. When this is a possible problem, when sexual violence is a possible problem for a patient, then you need to look at their entire person. And don't assume that another provider already has, because all too often we see that another provider has not necessarily looked at all of this person's body. Where there's intimate partner violence and sexual violence, we see a lot more physical injury on patients' bodies. So if you don't take that opportunity to look at that patient then and there, you may miss something that's really important. We talked about strangulation a few minutes ago, but really educate yourself on the lethality and the commonness or the commonality of strangulation so you can assess for it properly. And we worry about strangulation in younger patient populations. The health risks associated with elder populations who are strangled is much higher because they already have existing health problems. They may already be on medication that causes increased bleeding times. They may be on medication that predisposes them to a whole host of health issues. And so strangulation can be a very dangerous thing for that patient. So you want to make sure you can assess it properly. The other thing is that if you are within the window of evidence collection, that 5-day window, then talk to that patient about what their rights are, that they have a right to evidence collection, and talk to them in a way that actually is informed consent. Informed consent involves more than just signing a piece of paper, and one of the things that we teach sexual assault nurse examiners is consent is a process. It can be given at the beginning of the exam and be taken away 5 minutes in. Informed consent means all throughout the process the patient is in agreement with what you're doing and has the capacity to consent for that exam. Because if you're collecting evidence, what should be happening with that evidence is it should be being handed over to law enforcement in the jurisdiction where the crime took place. And in order to do that, the patient needs to know what's going to happen to that. There are typically local, sometimes state protocols that involve specific evidence collection kits, and those are the things you want to use if they're available. If you're not familiar with your local protocol or your state kit, emergency department staff typically are. The Sexual Assault Coalition for your state or the local community sexual assault crisis center are. The state health department may even be aware of what the process is in your particular jurisdiction. It's important that providers understand exactly what the evidence collection options are because of law changes. Patients have the right often to choose to have evidence collected even if they don't yet want to speak to law enforcement, if they don't yet want to cooperate in any type of an investigation. And that's something we refer to as anonymous evidence collection. Lots of providers are unaware of this, and so they skip that option for the patient when it should technically be offered. So you just want to make sure you're well aware of what is available in your jurisdiction for patients and that it gets properly offered. The other thing is when evidence collection does go on, it should go on in the context of all the rest of the patient's care. So as you're doing your physical assessment, if evidence collection is warranted, you're doing that at the same time. So the patient doesn't have to go through two completely different exams. I'm just going to go through a couple of pieces of the kit here really briefly. Often what you typically would find in an evidence collection kit includes something called a buccal swab or an oral swab. Typically it includes both in an evidence collection kit. The buccal swab is used to collect a swab of the inside of the patient's cheek to establish their DNA. It's not looking for someone else's. So it, always needs to be collected. Oral swabs are collected when the patient reports or you're suspicious of the patient having been orally assaulted and it's looking for someone else's DNA. The other thing that you will see in evidence collection kits are genital swabs, typically the external genitalia in a male or female patient, penile swabs in a male patient, vaginal and cervical swabs in a female patient. And it's important to recognize with the elder population that some elders may not be able to tolerate a speculum exam. The lack of estrogen can cause that exam for the elder to be more painful than it usually would. So it's important for the provider to be able to assess and then decide whether it's appropriate for that patient to have a speculum exam. The other thing to keep in mind is the patient may have more injury because of a lack of estrogen. So really good assessment of the genital area needs to happen. But the other thing to keep in mind is where we find the most DNA in sexual assault evidence kits is cervical and vaginal swabs, or where somebody put their mouth on a patient, gathering swabs that end up being a saliva sample from the offender. All of those are places we often find DNA. You may be asked to collect blood for evidence collection. This is pretty rare these days because you can get the same DNA sample of the patient with a buccal swab, which is less invasive. So that may be something you see. It's not a bad idea to find out whether or not you could use a buccal swab instead. But documentation probably makes up the majority of what we do as sexual assault nurse examiners. You want to make sure the patient history is included in the information you gather, specifically quotations about what the patient says about the sexual assault. A complete physical assessment, review of systems should also be documented in the medical record. That medical record review and any problems with things like patient cognition or the patient's ability to consent because they may not be their own guardian anymore. So those are issues you may want to watch out for. And then photography is another part of the exam, particularly when injury is present. It's important that injuries be recorded using appropriate body maps and diagrams, documenting the type of injury, the location, the size, the color of the injury, and not making any inferences as to what the age of the injury is, particularly in elders. There's lots of reasons for different types of injuries lasting different periods of time. When photography does occur, there needs to be a consent process. There needs to be a procedure for photographing. There needs to be camera equipment that's used by the institution, not cell phones by staff people. That should never happen. In fact, there should be an explicit ban on the use of personal cell phones. And there should be a compliant with HIPAA backup and storage policy. So all of those things you want to keep in mind, but also one of the things that we frequently are asked to do in the emergency department setting is use the police officer's camera to take injury pictures of the patient and then give the camera back to the police. Photographs are part of the medical record. They become part of the medical record when we take those images. They don't go off to another facility. You are bound by privacy regulations. Law enforcement is not. Don't ever use someone else's camera from a different agency to take a patient's injury photographs without express permission of your facility. Okay. The other thing is treatment considerations for sexual assault victims include pregnancy prevention, which in the elder population is limited, but it does take place. We certainly see women who fall into the category of older adults who are in their 50s and are still capable of becoming pregnant. So you want to make sure that that's part of the process, even though you will use it in a very limited fashion. We also typically prophylax for sexually transmitted diseases, including gonorrhea, chlamydia, and trichomonas. And if you're not used to taking care of sexual assault patients, HIV, non-occupational post-exposure prophylaxis is something that is routinely offered in concerning cases where the patient may have been exposed to HIV. So it's important, too, that you familiarize yourself with that. And in elder populations, sometimes you do get occasion to see enough injury that requires repair. So that may come up as well. Some of the other treatment considerations, of course, are patient safety and reporting requirements. If sexual violence is part of the picture, you really need to know what your state and territory laws say with regard to what you have to report and who you have to report to, and in what type of timely fashion does the report take place. Adult Protective Services may be called Adult Protective Services in your area or may be called something else. Typically, they do things like assessment of risk, assessment of capacity, case planning and intervention. They may do civil court orders of protection. They may be involved in housing and economic services. The key is to find out who is your quote-unquote adult protective services and what do they provide for services. And then collaboration within and outside your healthcare system is very essential to effective response in sexual violence. Whether you pursue formal collaboration in the form of elder response teams or informal collaborations where you know the parties that are collaborating, law enforcement, adult protection, elder law attorneys, a whole host of folks, and you communicate with them in a more informal versus formal way, having the collaboration improves the care for that patient and improves the community approach actually to sexual violence against elders. You can see here that the elder is always at the center, but any of these folks that you see on the screen can be involved in the collaborative process. And often the goal is to improve the community-based response to sexual violence against elders and hold offenders accountable. So somewhere in that arena, there's a goal that the team decides that they're working toward, and it usually involves both those things, but in a victim-centered way. So again, that elder is at the center of all of it. The services you see here are services that the National Aging Network provides, and that may be something you're aware of. It may be something you're not aware of. You will find information on this in the end of the guide, in the resources section of the guide. So be aware of that. I think you'll find a whole host of resources available in the guide that can help you that you may not have been aware exist. So with that in mind, let's just do a couple of questions for you to reflect on, really, regarding what you know about your own processes and how you think you can improve services for elder victims of sexual violence. So the first question is, do you know your facility's current policy when sexual violence is suspected? That's a fair place to start and find out whether or not there even is a policy at your facility. And if not, you definitely should have one. So excellent place to start. Also, are you considered a mandatory reporter in your state or your territory or your tribe? And if so, when are you a mandated reporter and under what circumstances? Who do you report to? And again, you can find the answers to those questions if you don't have them in some of the resources within the guide. Who is your local community-based sexual assault advocacy program? Who are they? Can you access them 24 hours a day? The best case scenario is if you see a sexual assault patient, you call an advocate, they come in, and you introduce them to that patient. And you give them time alone with that patient to talk about the services available through their program. It's a unique opportunity for the patient to be hooked into services ongoing that address the sexual assault itself. And then given what you've learned here, how can you improve your already existing response to elder sexual violence? Are there things you can think of that you learned in this session that you think we could do that and we would be doing a better job? Maybe you're doing an exceptional job now, but what could you do to improve? Because I think all of us working in this field understand that we're constantly in a state of trying to improve. And then just to summarize, elder sexual violence is a reality that healthcare professionals need to recognize and be prepared to effectively respond to. The key is access to the medical forensic exam services, whether or not evidence collection is warranted, and by professionals who are educated in how to conduct that medical forensic exam so you know your patients are properly cared for. That does not necessarily mean it has to be a sexual assault nurse examiner. Plenty of other providers are educated in how to provide a medical forensic exam for sexual assault victims. What do you need to achieve that state at your facility? And then know your local resources, particularly, again, the advocacy services, and utilize them to improve your response to elder sexual violence. And with that, I would say thanks so much for joining us today, and I hope you found this informative.
Thank you for your wonderful presentation, Jen. We're just going to go through some references slides now. Please note that all of the information from this presentation is available in our technical assistance guide. If you'd like copies, physical copies of that guide, or if you'd like some further technical assistance from us, our contact information will be on the last slide of this presentation. You can also visit our website, which is also listed on the last slide, to download copies of the technical assistance guide and access lots of other great resources about working with survivors of sexual violence. Thank you so much.